Good morning to Doctor and to everybody watching. This is our critical appraisal on prognosis by Group 1 and Group 2. This article is a long-term cohort study conducted by Dan Larson and his colleagues in 2003. The study investigates the long-term prognosis of patients diagnosed with fatty liver disease. Fatty liver is a common liver condition that may occur due to excessive alcohol consumption or metabolic factors such as obesity and insulin resistance. Despite its high prevalence, the natural history and long term outcomes of simple fatty liver remain uncertain. The study included 215 patients who were diagnosed with fatty liver through liver biopsy between 1976 and 1987 in Denmark. The study population consisted of both non-alcoholic fatty liver disease and alcoholic fatty liver disease patients. These patients were followed over time using hospital medical records, as well as national patient and mortality registries to determine important clinical outcomes. The main objective of this study was to determine the long-term risk of developing liver cirrhosis and the risk of death among patients with biopsy-proven fatty liver. Another objective was to compare the prognosis between patients with alcoholic fatty liver disease and those with non-alcoholic fatty liver disease.
Moving on is to the internal validity where an inception cohort is used. The researchers involved 215 patients with historically confirmed fatty liver diagnosed through liver biopsy from 1976 to 1987. All participants exhibits pure fatty liver without inflammation, indicating they were recruited at a comparable early stage of the disease, consistent with an inception cohort. However, representativeness may be limited. A portion of patients, which is 35%, were recruited from obesity research projects, resulting in high prevalence of obesity in the non-alcoholic group. This suggests potential selection bias, as the cohort may not fully represent the general population with fatty liver disease. So in conclusion, the cohort is well defined and recruited at a common disease stage, but representativeness is partially limited. Regarding to the follow-up adequacy, it is strengthened by several factors. The first one is long-term and comprehensive follow-up. The study employed a long median follow-up period of 16.7 years for the non-alcoholic group and 9.2 years for the alcoholic group, which ranges up to 21.9 and 23.1 years respectively. This extensive duration is crucial for observation the long-term progression of chronic conditions like fatty liver disease. Second one is national registry linkage, where all the members of the cohort were linked to the Danish National Registry of Patients and the Nationwide Registry of Cause of Death, using unique personal identification number. This method ensures complete follow-up for all admissions, discharge, diagnosis, and cause of death, minimizing loss to follow-up. The authors explicitly state that this record linkage ensures complete follow-up. And lastly is active reclassification of alcohol status. Recognizing the potential for underreported alcohol intake at baseline, the researchers actively reviewed hospital discharge diagnosis throughout the follow-up period. If a patient initially classified as non-alcoholic later had an alcohol-related diagnosis registered, they were reclassified into alcoholic fatty liver group. These measures improve the validity of the group classification, with 9 such patients being reclassified, 2 of whom subsequently developed cirrhosis.
Now let us see how outcomes are measured in this study. The use of national registries enabled comprehensive and near complete follow-up, particularly ensuring accurate recording of mortality. Cirrhosis was identified using multiple sources, including hospital discharge diagnosis, death certificates, and histological findings were available, improving outcome ascertainment. This approach increases the likelihood of capturing cases over a long follow-up period, strengthening the reliability of outcome measurement. However, not all cirrhosis cases were histologically confirmed, and some relied solely on registry or death certificate data, which may reduce diagnostic accuracy. The authors acknowledge that death is recorded without error, but the cause of death may be misclassified, affecting validity. This may result in overestimation of liver-related deaths in alcoholic patients and underestimation in non-alcoholic patients, leading to differential misclassification between groups. Overall, outcome measurement is comprehensive but limited by potential misclassification and lack of uniform diagnostic confirmation.
So now I'll be presenting the adjustment for prognostic factors. So this study is partially adjusted for prognostic factors. Hazard modeling was used to analyze survival with comparison between alcohol and non-alcoholic fatty liver groups. This study is also accounted for age and time of entry using a delayed entry method, which helps reduce the bias related to difference in baseline age and follow-up duration. However, these adjustments is an important prognostic factor. Important prognostic factor was incomplete. Alcohol intake was self-reported, introducing the risk of underreporting and misclassification, which key metabolic factors such as diabetes and hyperlipidemia were not systemically assessed. In addition, BMI data were incomplete and hepatitis C was not tested at baseline, leaving the potential confounders unaccounted for this. So the conclusion of the slide is adjustment was performed but not comprehensively, resulting in possible residual confounding that may affect the validity of the study's conclusion.
So, what are the results of this study? This study uses Kaplan-Meier survival curves to show long-term prognosis of fatty liver for follow-up until 23 years. This method sees censored data and show comparison of survival probability over time between the non-alcoholic fatty liver NAFL group, the alcoholic group, and the general population. The study uses Cox proportional hazards model, which allows for adjustment to confounding variables such as age and sex. This is to ensure the differences in survival not only due to demographic imbalances. For comparison, the results shows a statistically divergence of p-value less than 0.01 between survival of alcoholic group and the NAFL group. In precision, mortality and survival precision states that this study provides high precision regarding the survival of patients with type 1 NAFLD. The survival curve for the general Danish population remains within the 95% confidence interval for the NAFLD cohort for both genders. This narrow overlap provides strong statistical certainty that simple fatty liver does not result in excess mortality. In cirrhosis risk precision, the precision for the secondary endpoint, which is the development of cirrhosis, is lower in the non-alcoholic group due to the low number of events. Only 1 out of 109 patients, which is 1%, develop cirrhosis. According to the Oxford Appraisal standards, an estimate based on a single event is less precise than one based on many, as the true population risk could vary. However, the study compensates for this with an exceptionally long median follow-up of 16.7 years, which adds clinical weight to the precision of the benign finding. In impact of follow-up completeness, the precision of all reported results is strengthened by the complete follow-up achieved through the Danish National Registry of Patients, with only 4 patients, about 1.8%, lost to follow-up. The risk of missing an outcome that would change the confidence intervals is minimal. In alcoholic comparison group, in contrast, the precision for the alcoholic group is higher because there were more events, around 22 cases of cirrhosis and 79 deaths, allowing for a more stable estimate of their poorer prognosis. So what are the key findings of the study? In risk of cirrhosis, the non-alcoholic fatty liver group has a 1% chance to develop cirrhosis, meanwhile the alcoholic fatty liver group has a 21% chance higher to develop cirrhosis. In mortality, there is a higher mortality in alcoholic fatty liver group, which is 74%, versus the non-alcoholic group, which is only 25%. In prognosis, the non-alcoholic fatty liver disease type 1 has a benign long-term prognosis, while alcoholic fatty liver is associated with significant risk of progression and death. In overall interpretation, alcohol consumption is a major determinant of poor prognosis. Pure non-alcoholic fatty liver disease without inflammation does not significantly increases mortality risk.
Applicability means how well the study results can be used for our patients in real clinical practice. I will discuss the similarity to the patient population. First, histological match. The study used liver biopsy to confirm pure steatosis, so the diagnosis is accurate. Second, clear categories. Patients were divided into non-alcoholic and alcoholic groups, making results clearer. Third, realistic setting. The study was done in a general hospital, so it reflects real-life practice. Lastly, long-term data. The follow-up was 16.7 years, giving reliable long-term results. Next one is the applicability of the findings in clinical practice. First, reassurance of the type 1 NAFLD. This study shows that type 1 NAFLD is generally a benign condition with no excess mortality, so clinicians can reassure patients and avoid unnecessary anxiety. Second, targeted monitoring. Patients with higher risk, such as those with alcoholic fatty liver and about 21% risk of cirrhosis, should be followed up more closely. This helps prioritize care for those who need it most. Third, resource allocation. These findings help clinicians avoid over-treating low-risk patients, especially non-alcoholic cases, and instead focus resources on higher-risk groups. Lastly, focus on subgroups. It highlights the importance of distinguishing simple steatosis from more severe forms like NASH as management and prognosis.
So, overall strengths, there are 4 points. First one, long-term follow-up. The study featured a median follow-up of 16.7 years of the non-alcoholic group, allowing for a true assessment of long-term outcomes. The second one is data reliability. The use of Danish National Registry of Patients and the Registry of Causes of Death ensured virtually complete follow-up through unique personal identification numbers. Third one, histological verification. All patients had a baseline diagnosis of pure fatty liver verified by biopsy, excluding those with existing inflammation or other chronic liver disease. The fourth one, statistical rigor. This analysis used delayed entry to account for both the age of the patient and the time of diagnosis, reducing age-related bias in mortality comparisons. Next one is for overall weakness. Selection bias. A significant portion, 35% of the NAFLD group was drawn from obesity research projects, which result in a cohort of morbidity obese individuals that may not represent all NAFLD patients. Next, self-reporting limitations. Alcohol intake was based on medical records at the time of biopsy. The study acknowledged that patients often underreport consumption. The third one, missing baseline tests. There was no systematic testing for diabetes, hyperlipidemia, or hepatitis C at the start of the study period. And the fourth one is diagnostic evolution. The diagnosis of cirrhosis for some patients was based on death certificates or clinical signs rather than follow-up biopsies, which could lead to minor misclassifications. To conclude this journal critique, the results are considered highly trustworthy for clinical application. While the study is retrospective, the authors cross-reference pathology registers with national registries to maximize diagnostic validity. The clear divergence in survival curves strongly supports the conclusion that pure steatosis in non-alcoholic patients is not a primary driver of excess mortality.